So, good evening, everyone, and thank you, Dr. Raghu and KSOS for the opportunity. And regarding epidemiology, trauma, as you know, is more common in young males, and in the mechanical injury, closed globe injury is most common. It is 77%, and open globe injury is 23%. The issue with any traumatic glaucoma is that most of them are unrecognized because people forget about their old trauma and the diagnosis gets delayed. And this is one of the cause for preventable glaucoma. Predictors for glaucoma development include poor initial visual acuity, advancing age, the presence of lens injury, angle recession is one of the most important parameter, 180 more than 180 degrees, higher baseline IOP, and presence of hyphema. Classification of globe injuries are like mechanical, chemical, thermal, and electrical, and most common will be mechanical injury. In that, it is open globe and closed globe, and the causes of glaucoma could be early onset of IOP elevation and delayed onset. So, the most common cause of an IOP elevation and glaucoma could be the large percentage is because of a mechanical trauma. The direct impact leads to change in shape of the eye. What happens is that the anteroposterior globe compression happens. There will be equatorial scleral expansion and limbal stretching, and this stretching is what causes problem. Posterior displacement of lens iris diaphragm, sudden IOP rise, and splitting or tearing of tissues happens. These are the 7 rings of Campbell that is important. What you see here is this the iris sphincter, that tear happens, the sphincter tear. Iris base, what happens is the iris dialysis happens. Anterior ciliary body, the angle recession, where you see the longitudinal and the horizontal fibers splits, and the ciliary body, what happens, cyclodialysis cleft, what happens is the cleft develops. I will come to that subsequently. So, trabecular meshwork tears or zonular dialysis can happen, and also retinal detachment and retinal dialysis can happen. Early onset, what happens, the IOP elevates because of, first thing is inflammation, trabecular meshwork disruption, and also hyphema. Major reactions from trauma that leads to high IOP is because of secondary to outflow obstruction, trabecular meshwork inflammation. This outflow obstruction can be because of inflammatory cells, debris, or protein. Usually it is self-limited. Close monitoring is required. Acute suppressants are given. Topical steroids and cycloplegics are required. Trabecular meshwork disruption are usually missed because it is a subtle finding that you could see. It can lead to early and late glaucoma. Careful inspection and always bilateral comparison is required with good gonioscopy. It could be coexisting with inflammation, and definitely hyphema and recurrent hemorrhages can happen. Hyphema, madam has already covered, isn't it, ma'am? So, most important thing is, like, whenever you see that early signs of corneal staining, that immediately needs to be identified. Never leave the patient to be in this stage of corneal staining, and this is something that you never want. Delayed onset of glaucoma, that is very important because patients usually forget that history of trivial trauma that they have had. Angle recession glaucoma is the most important thing in that it is a common cause of glaucoma after contusion. The visible marker of invisible trabecular, we are not looking, angle recession is not the cause for glaucoma per se, it is the invisible trabecular meshwork damage that has happened, that is the cause for glaucoma. The when there is an angle recession, almost always there is a hyphema that is present, and not every glaucoma angle recession leads to glaucoma. Just 7 to 9% leads to angle recession glaucoma, and when you have more than 180-degree involvement, that is when you usually get a angle recession glaucoma. And a most important thing is that these people are genetically predisposed to primary open angle glaucoma. Other eye also later might get a POAG. So these people are also to be on follow-up. This could be because of the IOP elevation, and glaucoma could be because of increased outflow resistance. The scarring happens in the trabecular meshwork, and there could be a membrane formation. It is an always an open angle glaucoma in angle recession. If at all a synechial forms part of healing. Signs of recession, hyphema is an indicator. Immediate gonioscopy is usually not preferred. Earlier we used to tell about 4 to 6 weeks it is deferred and all, but nowadays when you do that, not do that indentation gonioscopy, and it is not as traumatic with the four-mirror gonioscopy, earlier you can do, but let it immediately with the high presence of hyphema, you are not going to get that much of findings. The meticulous evaluation, it has to be bilateral comparative. It is always comparative gonioscopy that gives the findings. Signs of recession, the broad ciliary body band, the broken iris processes, and the abnormally white scleral spur happens because of the torn iris processes. So this is ASOCT, and ASOCT here what you see is that open angle, and just a minute. So this is a diagram that shows the normal attachment of scleral spur and the iris. There is a split between that is a scleral spur there, and this is the longitudinal fibers, and these are the circular fibers. A split there is what is called an angle recession. So that medical management is in the similar lines: lowering IOP, aqueous suppressants, prostaglandin analogs bypass the dysfunctional trabecular meshwork, so it is better used. Myotics paradoxically increases the IOP. ALT and SLT is not useful in ankle recession because the trabecular meshwork is damaged. And surgery, usually what studies have shown, the surgery has little more risk for failure. But it is the same way as other open angle glaucoma is managed. Other glaucomas that happens is because of the intraocular hemorrhages that can happen. Ghost cell glaucoma is happening because there are ghost cells. Those are the khaki colored cells because of the degenerated RBCs. Long lasting vitreous hemorrhages leads to degenerated RBCs, which comes and occludes the trabecular meshwork. And these are small uniform fine khaki cells, and they have tan colored hypopyon, that's called pseudohypopyon. Fresh hemorrhage layered by this tan colored hemorrhage is called candy striped sign. This is again medical management, and if the vitreous hemorrhage is severe and the glaucoma goes uncontrolled, you might need to do AC lavage and vitrectomy. Hemolytic glaucoma, it is an secondary open angle glaucoma days to weeks after intraocular hemorrhage. Here what happens that hemoglobin macrophages that free hemoglobin, and all those remnants clogs the trabecular meshwork, usually related to large intraocular hemorrhage. What you see is that on gonioscopy is the trabecular meshwork is reddish brown. The trabecular meshwork is occluded by the RBCs. Here refractive cases we might need to do AC lavage. Hemosiderotic glaucoma, what happens is that the iron content of the RBCs gets lysed, and the iron gets released, and this iron goes and damages the trabecular meshwork endothelial cells, and those scarring and degenerative changes, sclerosis and obliteration of intertrabecular spaces leads to glaucoma, and that is a hemosiderotic glaucoma, and it is usually associated with other features of cirrhosis. Hypotony happens for post injury, that in the acute phase is because of decreased aqueous production or increased outflow due to inflammation, and it can also happen because of what is called as cyclodialysis cleft. It is when you do gonioscopy, it is important to differentiate between a cyclodialysis cleft and a angle recession. Cyclodialysis cleft is seen as a white area of scleral spur that is clearly seen. Ciliary body is torn from the scleral spur. This importance is that the ciliary body is detached, and then there is a direct communication from the anterior chamber to the uveoscleral space, and this leads to hypotony. And when you when PAS forms, or when you close this cleft, it might lead to ocular hypertension later. And this is an example where you can see that the trabecular meshwork, the scleral spur and the iris root has detached, and there is a communication. And here again you can, in the ASOCT, you can see that cleft here, that is a bare sclera, and that space is a cleft. So penetrating injury 2.67% leads to glaucoma. Is usually advancing age, lens injury, the baseline visual acuity, inflammation, pre-existing anomalies all tells about the prognosis. The structural alterations, blockage of trabecular meshwork is a pointer. Again, we should always remember about this parameter of epithelial ingrowth, epithelial downgrowth and fibrous ingrowth that might also block the angles. When there are intraocular foreign body, this siderosis thing and the chalcosis also has to be remembered. In chalcosis, the glaucoma is usually little rare. Chemical burns can also lead to glaucoma because of tissue shrinkage and disruption of the trabecular meshwork, and this lead to chronic inflammation. Trabecular meshwork is affected because of the inflammation also. Ciliary body necrosis can happen in alkali burns. After the most important thing is treatment is difficult after a chemical burn because the conjunctiva is scarred. So any glaucoma surgery ideally depends upon the conjunctival health. Nowadays mix and all are coming up where conjunctiva is spared, but routine glaucoma surgeries are conjunctiva dependent. Thank you. Just wanted to show this case where every finding possible in trauma is there. That is an iris hole there. That's an ASOCT picture. That is a PAS that is in the yellow round. And this patient had both this, that is angle recession over there and cyclodialysis cleft. So one patient with all the findings. Just that. Thank you.